Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with a right-sided ear infection. In addition, they also had a really swollen, watery and inflamed right eye. And they explained to me that they've not been feeling well for the last fortnight or so. They've had a really bad cold. And it may well be that this patient is suffering from sinusitis or allergic rhinitis. And the reason I say that is because, as well as this outer ear infection called otitis externa, as you can see, I'm just performing microsuction and I'm just removing all this dead skin, debris and outer ear. They are also suffering from a middle ear infection called otitis media, or more specifically, acute otitis media with effusion, which is also typically known as glue ear. So if you have sinusitis or allergic rhinitis, the infection can travel up the back of the eye, causing the patient's eye symptoms, so causing it to be inflamed, watery, and swollen. But it can also block the Eustachian tube. And the Eustachian tube is a pressure equalizing tube and also a drainage tube behind the eardrum, which connects to the back of the nose. So the middle ear, so the cavity behind the patient's eardrum, should be full of air, it should be air-filled, and the air pressure behind the eardrum should be equal to the air pressure in the atmosphere. And it's the responsibility of the Eustachian tube to equalize the air pressure. The Eustachian tube is typically shut, but during the course of the day, without you even noticing, when you swallow, yawn or chew, it momentarily opens up the back of the nose, allowing the air pressure to equalize. In addition, when the Eustachian tube does open, it allows any fluid that accumulates behind the eardrum in the middle ear to drain out, because we don't want fluid there. However, when you have sinusitis or allergic rhinitis, it can block that Eustachian tube, which means there's negative middle ear pressure. There's no air behind the eardrum. It's absorbed by all the cells in the middle ear, which then creates a suction effect, a cupping effect, and the eardrum gets sucked in. And then if that Eustachian tube doesn't resolve, fluid that would normally drain starts to collect behind the eardrum and it fills it up in the middle ear. And instead of the middle ear being full of air, it's full of fluid, and this fluid then becomes infected, becomes very viscous, and hence the term glue ear. And I'm just working on the eardrum now, and you can see it's extremely bulged. There is some discharge here, so I was wondering whether there was a perforation, but I couldn't see a perforation. And the giveaway sign that there's no perforation, and you'll see it in a moment, centrally there's a big bulge there. You can see it beating. So this patient has got fluid, the glue ear, behind the eardrum, and it's causing the eardrum to inflame and bulge. And it's possible that if this is not resolved, that this patient's right eardrum can perforate, it can explode, it can burst open, it can pop, because it's too much fluid. So think about a water balloon. If you put too much water into the water balloon, eventually it's going to reach its max capacity and the water balloon is going to pop. And again, you can probably see that even from here. It's popping away, it's beating away this eardrum. Now, it's possible that maybe this eardrum was already perforated and all the discharge from the middle ear entered into the ear canal, and it was only a small perforation, and that perforation has since healed, and again you've got another collection of fluid. But it's difficult to tell, but I suspect they've actually got two infections. And they're separate. They've got otitis externa, which is an outer infection, as I explained, and we'll call it acute otitis externa because there's inflammation and swelling and discharge. We call that acute otitis externa. You can get superficial otitis externa, and that's when patients have a bit of dry, flaky skin. There's not really much inflammation. There's no discharge, and again, you can see that the inflamed eardrum, it's bulged in several places. There's about 3 or 4 bulges there. So I've cleared the eardrum, and now I'm just mopping up near the entrance. There's a couple of occasions where the patient suffered from the gag reflex, and you'll see me just kind of move away. So when we're working on the cartilaginous portion of the ear canal, we can make contact with the cartilaginous portion. We've got to be still delicate because the inner 2/3, of course, is extremely sensitive. It's made up of bone. Whereas the outer third of the ear, the cartilage portion, you can apply a bit of pressure because it's a bit flexible. It's not as rigid as the bony part of the ear canal. But there's a series of nerves just underneath the canal wall, and if you apply too much pressure, or just it's unavoidable at times when we take impressions of people's ears for hearing aids or ear defenders or musicians' plugs or swim plugs. We insert a piece of cotton wool on a piece of string so we can remove it afterwards, and we syringe some putty material to take the shape of the ear. That can also activate the Arnold's nerve, which is the branch of the vagus nerve, and it can cause the patient it can elicit a gag reflex, a cough reaction. You probably just saw it there momentarily, but we continue, and I think it's once more just there. You could see that they just moved and just coughed, but it was very short-lived, and I was able to still continue in the ear, truth be told. So I'm just trying to get some of this debris out of the ear near the canal. Now, we've written to the patient's GP. They're going to need some antibiotics, I suspect. I've also, until that, in the meanwhile, advised them to use some over-the-counter nasal decongestion spray to try and help unblock the Eustachian tube. And for the outer ear infection, I've advised acetic acid spray, which the patient can get over the counter. They will require prescribed, however, medication for the outer ear infection as well because of the inflammation. But in the meanwhile, it's better than nothing using the acetic acid. The acetic acid helps to reacidify the ear. The ear should be naturally acidic in pH, but quite often when patients experience outer ear infections, the pH level changes from an acidic pH to an alkaline pH, and the acidity in the ear helps to inhibit bacterial and fungal growth. So the acetic acid, the concept behind it is to reacidify the ear, make the ear an acidic environment again to help fight any infection or any bacterial or fungal infection. You can see I'm just using the fine end just to get all this skin. Now, the skin is obviously it's just soft and soggy. It's just coming away from the canal wall because the patient's ear was full of discharge, all that moistness. You can see you saw the inflammation at the entrance of the ear and all the discharge at night. So the patient does live alone. So I've asked the daughter when they go back home just to check her pillowcase, because I suspect there's going to be a lot of discharge on that from the right side when they're leaning over, if they do sleep that side, of course. So yeah, all the discharge, all the moistness and dampness in the ear, it causes the skin to die and become soggy. We're just trying to remove as much as we can. So we've written to the patient's doctor already. In the meanwhile, whilst they're waiting an appointment and prescribed medication, they're going to use some over-the-counter treatments to try and avoid this eardrum from exploding or imploding, should I say. And again, you can just have a final look, and we're going to see that fluid behind the ear. You can really see that beating away, and you got like a bulge at 10 o'clock and also at 3 o'clock. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Thank you, bye.